insulins, that these are the right objectives. I'd forgotten I'd done those. Oh, okay, so let's talk about insulins. So we're going to talk about generic things about insulins to start with. We're going to talk about insulin preparations. So insulins now are kind of divided into, you have human insulins and you have analogs. Human insulins are called human because they are designed, or they're built to look like human insulin. So sometimes patients will think they've taken insulin from humans. They don't do that. They don't do that. We used to take it from pigs and hogs and cattle, but we don't do that anymore. We don't make animal source insulin. So human insulin means it looks like human insulin. And the way we do that is through recombinant DNA techniques. Really cool. So we make these little E. coli work for us. They don't unionize, they never go on strike. You can kill them off and there's tons left. So what we do is we encode their DNA with making a B chain and an A chain. And then we just harvest it. We also do it with yeast. So another company that makes insulin uses yeast, and Lilly uses E. coli. So we harvest those chains and then we put them together and we have human insulin. So its primary and secondary structures are the same as human insulin. They're tertiary structures. The way that protein folds looks a little bit different. So sometimes you can evoke an immune response to insulin because of that. It's not very common to get a full-blown immune response, but you can get enough antibodies to decrease the effectiveness of the insulin. It doesn't happen all the time. Usually we don't worry about it unless we just can't get a good therapeutic effect. So that's how we make recombinant DNA insulin. You're familiar with this. This is an insulin molecule. You've seen that with the, kind of looks like a backwards E. And that's pre-proinsulin, proinsulin, B chain, A chain, C peptide, and then we get to insulin. So we can take that amino acid sequence and we can manipulate it to change the pharmacokinetics of the molecule. That's what an analog is. Okay. So here's some examples. This is Lispro is yellow, Aspart is green, Glargine is pink, Detamir is gray. The yellow and the green are rapid-acting insulins. So we can, by just making one amino acid shift or substitution, we can make it so that that insulin will absorb very quickly when we inject it. So when we inject insulin, it usually will form what we either call monomers or hexamers. The more it will stay as a monomer, the faster it will absorb. If we make hexamers, very slow absorption. So we can manipulate it to get what we want. So the Lispro is we are just exchanging a lysine for a proline and a proline for a lysine. We just flipped it. And the Aspart, we took asparagine and we substitute for the proline. Isn't it amazing? Okay, so there we make rapid acting. Then we take Glargine and we put these two arginine on the very end of the molecule and we make the pH low. We make the pH 4. So Glargine has or Atlantis or the JO, Valsagar, all of those are Glargine insulins. So that insulin, because its pH is 4, when you put it into tissue that's a pH of 7, it precipitates. And it precipitates and forms these complexes that are very slowly absorbed. So that way we can get a 24-hour insulin. Whereas for Lispro and Aspart, they're gone in 3 to 5 hours, fully absorbed. Detamir, we put this big fatty acid chain on it, slows it down. It's the same thing as in terms of Absorption, very, very slow. Okay? So that's how we manipulate a naturally occurring molecule to behave like we want it to. So why would we do that? Well, when we have to replace someone's insulin therapy, we're trying to make it as close to physiologic as we can, because then we can get the right physiologic response. The only difference is we can't put it into the portal vein. So when we inject insulin, we inject it into subcutaneous tissue. So that does change the physiologic effect of the exogenous insulin that we give people, or replace their own insulin. Or we augment, like in type 2, they still make insulin. They just don't make very much, and they don't release it in a pattern that works to control blood sugar. In type 1s, we have to replace all the insulin that they would have made. So we can use these manipulations to approach what the body normally would have done for itself. Okay. So that's how we make it. So it's very important to have some terminology. Analogs, human insulin. Then we'll talk about insulins versus how rapid their onset is. So this terminology you must know. It's used quite a bit. Rapid acting insulin analogs. Those are Humalog, Novolog, and Apidra. I'll come back to these little different dosage forms in a little bit. The long-acting insulin analogs are Lantus or Glargine and Levemir or Detamir. So all of those other names, those are also Glargine insulins. So then we look at time course of activity. This brings in the other human insulins. Rapid acting, Humalog, Novolog, Apidra. I can guarantee you I'll ask you a question that says, which of the following is a rapid acting? Or this drug, is it rapid acting, short acting, long acting, intermediate acting? Short acting is regular. Regular was the first mealtime insulin that was made. And it's fairly quick, but it's not as quick as the rapid. I'll show you some time frames here in just a second. The last three, the intermediate, the long, and the ultra-long, are the ones we use for basal insulin. So the intermediate or NPH, again, that's one of the first basal insulins that was produced. Been around a long time. Neutral protamine Hagedorn. Hagedorn was the man who devised the makeup. Protamine is the protein in it that allows it to be absorbed over a long period of time. Neutral tells you about the pH. Long-acting, Lantus, Levemir. Ultra-long-acting, the newest one, Tresiba, has commercials all over the network. Now you'll hear these stupid things and you'll go, can't ignore them anymore, because now you've heard about them. It's very important to have an understanding of their relative pharmacokinetic curves or their action curves. So this you have to know, this chart right here. The reason why is that if you know the onset, you know when the insulin has to be administered. If you know peak, you know when the most glucose lowering action is present, and that's usually when the people are most, take that back. One of the reasons you want to know peak is that we can match up the peak of the blood sugars rise after a meal with the peak activity of insulin. Sometimes with the peak, we also get the highest risk for low blood sugars, particularly if the person has under-eaten the amount of carbs that we were anticipating them to have. Effective duration of action will also tell you when do you have to dose it again. May also give you insight as to when a low blood sugar is going to occur. Whenever low blood sugar occurs, you have to know what insulin is most active at that time, because that's the one you're going to modify, or you're going to modify what they're. I don't usually modify what people are eating. I will modify an insulin to match. People will get into a mindset if I'm eating because I have to take insulin. No, you take insulin because you have to eat. Okay? It's a different way of thinking. So I'm going to modify the drug before I modify the food. Okay? I'll give you some examples when we get to cases. Okay, questions about those? Okay, let's look at this again. So onset. So when you look at the rapid-acting Humalog, Novolog, Apidra, you see their onset is very quick. So they have to be administered very close to the time the person eats. If you don't, they'll get low because that insulin will get in and it will distribute any glucose that is present, and they can get too low. Effective duration about 2 to 3 hours, but in the reality they last about 4 to 6 hours. So they have to be re-dosed every meal. Regular onset is 30 to 60 minutes. So we usually have to administer that one a little bit longer before they eat because it takes it longer to get absorbed and to rise in the bloodstream. Peak is a little bit delayed, but the effective duration and maximum duration is a little bit longer. Sometimes we can take advantage of that and just dose it twice a day, like breakfast and supper. But those first three, Humalog, Novolog, Apidra, they have to be dosed at every major meal. NPH, its onset's a little bit delayed. NPH is an interesting insulin. It's kinetics. There's lots to take advantage of with it. It's an older drug. It got supplanted by the Levemir and Lantus, but it's becoming more popular again because it's cheaper. You go into Walmart and buy a vial for $25. Lantus will cost you about $160. So cost is starting to drive people back to the older products. So with NPH, when you take it in the morning, you get this kind of profile. So we have to give something with it with breakfast because NPH ain't going to cover it. But it starts at about the time you get to noon. You're getting pretty good levels of it, and they're sustained through the afternoon until about the time you get to supper. And then the dose starts to attenuate. So we've used that property to sometimes we give a meal insulin here with the NPH, and then we don't give a meal insulin here because we get a pretty good peak from the NPH. Say sustained through the afternoon. Problem with that is that you get your low blood sugars can occur there if there's not enough. If they haven't eaten enough for lunch based on the dose you gave them. And then we usually have to redose it here, either at supper or at bedtime. Lantus and Levemir, Tresiba, they're going to be like this. So when they talk about a peak with an insulin, that's what they're talking about, the NPH. You get much higher levels in the bloodstream with NPH than you get with Levemir or Lantus. So I can use that to my advantages sometimes for a patient. I really like NPH overnight because in type 2s, hepatic glucose output can be really high. So NPH can give me a really good peak to cover that. Lantus and Levemir, not so much. Sometimes it's not powerful enough in a type 2. Okay. Or I can give it right at bedtime, and I can make that peak work for me overnight before and have enough insulin on hand when they get up that their blood sugars will be within normal range. So I can use it that way. So that's the way I use the kinetics of those drugs, action profiles, to match what's going on with the patient. I don't expect you to be able to do that, but I'm giving you some examples. What I do expect that you will be able to do with that information is that if I tell you a person's having a low at this time of the day, and here's when they eat, and here's when they take insulin, you should be able to tell me, here's the offending insulin. Here's the insulin dose and the insulin type that is causing that low. You have to be able to do that. If you're going to deal with people who are taking insulin, you have got to be able to determine what is the cause of a low. Lows will get them into trouble. People can sustain, people can deal with, the body can deal with a high much longer than can deal with a low. Can't deal with a low. Lows will kill you. Highs don't kill you as easily. Okay? So you want to keep lows from occurring. So it's always important to figure out, why did that low occur? What happened? What did you do? What did I prescribe that led to that? If you look at Lantus, onset slow, but once you start overlaying those doses, that's only with that first dose. Once you start overlaying doses, it's like almost a constant IV infusion. Tresiba, so their onsets are just delayed. So you see Tresiba, they're saying, is a peak. Whoops. So I pay attention to those. Atlantis, I think, also has a peak, because I have found that if I give it at bedtime, I often have people have lows at night from slight peaks. I don't want you to worry about those so much. Need you to know onset, I need you to know peak, I need you to know duration of effect. And for the fast actings, those effective durations are important to keep in mind. For the longer acting, it's that max duration of effect. Questions about that? Yes?
As far as insurance goes, do you have to start with a certain one and move on to a different one? How does coverage work? Because I remember for the brief time that I worked as a pharmacy technician, I remember this one lady that came in, she was irate because her insurance wasn't covering it, and it was some ridiculous price. So how does that work?
Well, for Novolog and Humalog, I find those are the two big contenders. So insurance companies will go to a manufacturer and they'll try to get the best price. And so manufacturers want a market, they want part of your insurance group. So they will preferentially price it and they'll bundle it with other products in their line. So it isn't uncommon in January, that an insurance will go, Humalog is our preferred, which means you pay the least copay. If you want to pay Novolog, you will pay more out of pocket for it. So that's what insurance companies do. They negotiate a price, and so you may have to change every year to a different rapid acting. It's usually Novolog or Humalog. We'll go back and forth. I haven't seen Apidra be that big of a player in that. So that's what you were seeing.
Yeah, I think it was either Humalog or Novolog that she was really upset about.
With the type 2s, I never worry that much about it. They have a huge enough width in terms of their resistance, the effective insulin. I don't worry about it. Type 1s, I worry more about it. They're more insulin sensitive, and so switching products can make a bigger difference for them. So type 2s, I don't worry about it. I know patients do, because they can perceive differences sometimes if they're paying a lot of attention. But for the most part, those drugs are almost identical in the way they act. Good question. Anybody else? Okay. Okay, on page 4, the other terminology you need to be able to use are bolus insulins, basal insulins. Bolus insulins are insulins that are given before a meal. So remember when we talked about the insulin release curve, you had a phase 1, phase 2. We talked about that initial phase 1 being a bolus, It's the same thing with this. It gives you a large amount of insulin over a short period of time. So bolus insulins are always going to be pre-meal insulins. Now, you may use them at other times. Pump patients will use them to bolus if they're having a high in between meals. They may bolus. But for the most part, bolus are going to be pre-meal insulins. So your pre-meal insulins are your rapid-acting analogs, Humalog, Novolog, Apidra, and regular. Your basal insulins are your longer acting. They are going to replace or augment the basal secretion of insulin that you normally your body would do. So NPH, Lantus, Levemir, Tresiba, Toujeo. Be able to name those. So those are the ways to category. By time course, by analog or human, that's probably the least, but time course and basal or bolus, you have to be able to put them into those categories. Questions on that? Okay, let's look at the time course on a graph that puts them all together. So here's plasma insulin levels on the y-axis, and on the x-axis it's over time. So with Aspart, that's Novolog, Lispro, which is Humalog, blue lysine is Apidra. When you inject them, they get into the system very quickly, within about 15 minutes. Their rise is very rapid, and their decline is also fairly rapid. The way we look at their decline is that they use up about 20% of that dose every hour. That becomes important later for when we have to redose it. So they're using it up at that rate. Regular, you can see, is a short-acting insulin. It's also a pre-meal insulin, but it's delayed. Its onset is delayed. So they have to inject it further, more in advance of a meal. And the peak is a little bit lower, but the tail of it, or this portion of the decline, is slower and longer. You really have to keep that in mind, because if you, let's say they take a dose here, and then they eat breakfast at 8. Let's say they eat breakfast or lunch at noon, and they're going to repeat that regular dose. They're not starting from here, they're starting from here. And so they give a dose and they go up here. So then they become more likely to have a low. So often when I use regular, I don't dose it 3 times a day. So if I come out here at supper at 8 o'clock, or 8 hours later, and I dose a regular here, I'm starting at this point. See what I'm? So what we call that is that if you are using if you are dosing rapid-acting insulins close together, then we call that stacking. So if a patient takes a dose of a rapid-acting analog here, let's say they check their blood sugar in 2 hours and it's elevated, and they panic and they take more. They are starting from here. And so they are then stacking the dose. They're stacking a dose on top of a remaining dose. So when I'm talking to patients, particularly with low blood sugar, I'm looking at if that is an aspect of it. Did you stack a dose? Did you take another dose and forget that there was already remaining insulin in your system? Insulin pumps do this. They are programmed to do that. They will calculate how much of the remaining dose from the time you last took insulin, and you're going to bolus again for another meal or a snack. It takes into account how much is left from that dose. Here's NPH, here's Detamir, this is Levemir, here's Glargine, that's Lantus. So with NPH, I was showing you that peak and a little bit more sustained that occurs. So again, onset, we've got pretty much full action in about 4 hours. So we're always going to dose that usually at breakfast or first thing in the morning. And then by noon, they've got pretty good sustained effect. throughout the day, and then by the time they get to supper, we're gonna usually dose this one every 12 hours. Then when we put it here, most of that drug is gone, insulin is gone, and we're gonna go up again. If we are doing it on an every 12-hour basis, then after a few doses, we're gonna get to a kind of a very smooth, a much more smoother curve. We won't have as much of this going on, because at here, we'll start dosing it again. So we won't be dealing with this time of NPH, it's a very attenuated effect. So let's say you take it here and then you take it here again. What happens by the time you get to 24 hours is that you're dealing with this tail end of the insulin dosing. So sometimes people will wake up with a higher dose just because the insulin effect is almost gone. Detamir has a little bit longer and higher insulin level than Glargine. It just doesn't usually fit for most people as a twice a day or as a once a day drug. So I don't like Levemir for that reason. Usually you have to dose it twice a day. Glargine, very nice drug, very nice kinetics, very smooth and even. In some people, you'll have a little bit of bump for the first 4 hours, and then it goes into this straight line. Very nice drug. Most people can get by with it as a once-a-day drug. Tresiba, it is a 36-hour, 42-hour drug, and so the reason why we still dose it at 24 hours is because here's your 24-hour effect. It's just a very slow attenuated fall-off. So we're going to dose it again on that 24-hour time period. You can't go 36 hours. It would be a nightmare for people to try and remember, okay, today I take it at 8, next day I take it at 8 p.m. It just doesn't work. So these are very low amounts of insulin, very low background. Okay, questions about that? So if someone is taking, let's say they're on Lantus, and they're taking Novolog or Humalog, and you're having a low blood sugar at this point in the day, then that's where those curves help you to start to figure out what insulin is causing that, is causing the low. So that's why getting these pictures in your mind about where the insulin is at the time that the patient's experienced a low or a high will help you being able to modify the insulin regimen. Questions? All right. Okay, so where do we inject these insulins? Where we inject is really important because it will change the absorption kinetics of the drug. So whenever we start somebody on insulin, we are always going over, here's the places where we want you to inject. And when you see somebody, you always want to ask them, where are you injecting your insulin? So abdomen, top of the hips, upper thighs, arms. I find the arms are hard for people because it's hard to sometimes do that by yourself. If you're injecting for another person, it's a good site. You want anywhere where there's good subcutaneous fat. If they are really thin, then sometimes the abdomen or the upper arm legs are going to be the better to go with. We always want them to rotate the site of injection. Because if you don't, what kind of hormone is insulin? Is it anabolic or catabolic?
Anabolic.
It's anabolic. It will build up fat pads. So if you can repeatedly inject into the same place, it'll lay down nice little fat for you. Now, this will resorb. This would take several months, but you could get this to go away by having them rotate their sites. The other problem that happens with insulin injections is sometimes you get these atrophied areas. That's an immunologic response to the injected insulin. So even, the one I've seen it happen with most is Humalog. We used to have it, it was terrible with the animal insulins because they produced a lot more of an immune response. But by repeatedly injecting there has been an immune response to that insulin and the fat has gone away. You can, again, by several things you can do there. One is rotate the sites. The other, by injecting a different insulin into that site, it will build up a fat pad. This again will take several months to restore that to normal. Questions about that? Oh, I got ahead of myself. Okay, so when do we inject these? So rapid acting insulins, I'm under number 6. So rapid acting insulins, we usually instruct folks to inject 15 minutes before they eat. So, especially with type 1s, we are going to base that insulin dose before a meal off of what they're going to eat. Okay? So that requires that they've already looked at that meal, they've already got a plan, they already know about how many carbohydrates they're going to eat, so they need to eat it all. So that's, you can see where problems start to arise. So if they are out ordering, they may look and they order their meal, they are going to anticipate the amount of carbohydrates and inject ahead of time. Injecting ahead of time will allow that insulin to be absorbed and start to rise as the sugar out of their meal starts to rise. That's what we want. That's what your body would do. Okay. For people who are very well controlled, their blood sugar before a meal is exactly where it needs to be, they might inject right when they eat. If they're low, they could even wait and inject later. I usually don't like people to do that, but folks who have lots of problems with lows, or can't always plan how fast they're going to eat, sometimes I'll have them inject while they're eating. I don't like that as well, but sometimes that's what you have to do to avoid the low. You have any stories to tell about that?
Not really. I just think the worst part is like sometimes my eyes may be bigger than my stomach, and I take insulin, and then I'm not even hungry for whatever's on my plate. But you have to eat something.
So what do you do?
I usually wait it out and then maybe drink something to cover that sugar load.
So that's the downside. The other time where you would have them inject after they eat is with little kids. That's a nightmare because you are planning how much insulin to give them, but they don't cooperate in how much they eat. So with those, you can wait until you've seen, here's what they ate, and then inject them. And with them, we allow for higher levels of blood sugar than we do with adults. So that's the rapid acting. For regular, it's about a 30-minute. That becomes difficult for people to do. You can see you're going to have to be organized, you have to be planned, you have to have your stuff ready. That's where I find a lot of patients they fall apart, especially in the evening. They don't have it all together, they forget, their things aren't there where they can get them. So talking to them about organization and how to try to help them is sometimes part of the conversation. You can also use that time frame to help bring down a higher blood sugar. Let's say before they eat, they're at 200. Well, if they eat fairly shortly, they'll just go from that 200 on up. So sometimes what I will work with them to do is inject, wait a little bit longer. Taking rapid acting, wait 20 minutes. Taking regular, wait 40 minutes. So you can actually use that increasing insulin concentration in the blood to lower that blood sugar before they eat. Because just like stacking insulin levels, if you start here at 120 and you eat a meal, you go up to here, your insulin can help bring it back down. We're really happy if we can get the insulin to bring it back down to where you were when you started, or within 30 points. Okay. But if you start here, and we want you to be here, you're already you're beyond what the insulin can do. So you've got to have correction factors in there to cover not only what they're eating, but then to correct a high. So we can use that, the knowledge of that, okay, where did I put my thing? Oh, you can use that knowledge then to bring the sugars down before they eat. Okay, basal insulin, so when do we inject those? Those are injected once or twice a day at the same time of the day without regard to meals. Okay? So it doesn't matter if you inject your Lantus and you don't eat breakfast, it doesn't matter. Okay? It does matter if you take your Humalog or Novolog or a Pediatric or a regular and then don't eat. That matters, because then you're at high risk for a low. Same time every day. We would like to, you can see now based on those profiles that we'd like it to be about every 12 hours if you're going to do it on a twice a day basis. Sometimes if they're always waking up high, it's better to put that basal insulin in the evening or right before bedtime. If they tend to wake up low or have lows in the middle of the night, it's better to move it to earlier in the day. Questions about when you inject? Let's see, we talked about where they're injected. It's subcutaneous, so for patients where it's going to be subcutaneous either with a needle or through a catheter like the pumps use. If we're acutely treating somebody in the hospital, then we're going to give it IV. And then we can't use all the different insulins IV, so we'll reserve that for when we talk about DKA treatment. But for patients who are daily injecting themselves, it's a subcutaneous. We want them to do that. So when they inject, we always tell them to inject down to the hub of the needle. If you do it too light, then your intradermal, that doesn't get absorbed as well, or in the same profile. Okay. So let's talk about how insulins come. Some of you have been at Good Shepherd with patients who are getting insulin from them, so you may have seen some of these. So insulins can come in vials that we use a syringe to draw up, or they can come in insulin pens. The vials have been around for 60 years. I like them, I like people to draw them up, but the drug companies have driven pens to the point where that's what we have. So very few people get vials anymore. The thing to remember with vials is they are standard. So they are standardized. Every vial has 10 mils of insulin in it, every one of them. All the vials are U100 insulin. I have lived to see it come full circle, so let me show you. When I was working for my dad as a kid, there was, and there still is in veterinary medicine, there's U40, U80, U100. Okay. What that means, it tells you how many units of insulin are in a milliliter of fluid. Okay? So U40, 40 units per mil. 80, U80, 80 units per mil. U100, 100 units per mil. About 40 years ago, they said it's too confusing, people are getting them mixed up. Except for veterinary use, we got rid of them. We standardized all insulins to U100. So if a vial is 10 mils, how many units are in a vial?
1,000.
1,000, okay? So it's good to know this, because when you figure out how many vials or pens a patient needs, you got to know how many units are in the volume that you're dispensing, or that they're going to get dispensed, and how many units a day they're taking in. That helps you know how many vials or pens to prescribe. Okay? So that's all standard. So that's the vials. With the vials, you have to have a syringe that pulls it up. Let me skip over to that. That probably makes more sense. So look at number 5. So you'll see in these, here is a syringe. Here's a syringe down here. Syringe come in different volumes. Okay. These are pretty standard. This syringe will hold 100 units of insulin. This one is called a low dose. It will hold 50 units of insulin. This one will hold 30, this one will hold, that one's a 30, they make a 25. These are, you can see the barrel is where the units are listed. For the smaller ones, they're going to be usually one mark is 1 unit, except they do make some for children that are marked off in half units. For adults, we don't usually use that. So the needle's already attached, this is the plunger and the cap. So the patient will, so the patient is going to insert that needle into the vial of insulin, and they're going to draw up the amount of units they are to inject at that time. So there's a technique to learn. It's a little bit awkward, but patients can get the knack of it. They can mix insulins in the same syringe. They just have to know what order to do them in. You can see that most insulin is clear. Levemir, Novolog, Apidra, these are all clear. NPH is the only cloudy insulin. It's a suspension, so it looks cloudy. So sometimes I can figure out what a patient's using by saying, is it clear or is it cloudy, if they don't know anything. That, you can't really see it through these, but these are all NPHs. They are a suspension. All these others are a solution. Okay. So when we prescribe syringes, we prescribe it based on the volume the patient has to draw up. So if they're using big amounts of insulin, say they're using 50 units or more, then we're going to have them use this syringe. If they're using 30 to 40, then we'll use this syringe. So you can see the problem, and the reason why we don't go usually up to the full amount. The further you pull that plunger back, what's the worst thing that can happen? Plunger comes out and all the insulin goes on the floor. So usually when we get to about 40 to 45, we go up to the next size. With the 30, when we get to about 25, we go up to the next size. The reason to use these smaller syringes for smaller amounts is that the barrel is more accurate. It is spread out, it's easier to see, and the markings, they can read it more easily. So you would designate in a different prescription, these require prescription, what size of, so you would put a 1 unit or a 1 mil, these are 1 mils. This is usually referred to as a low dose. This is a 1/3 cc or a 1/4 cc. When insulin first came out, it's an OTC, so NPH regular can be bought without a prescription. Needle syringes also can be bought without a prescription, but in Oklahoma County, they cannot because they require a prescription because of the abuse. Or people coming in and getting it for other uses. So you'll have to write a prescription. I just write a prescription for all of them. I don't worry about whether they can get it without or not. Okay, so those are the syringes and vials. So probably 30 years ago, they started making insulin pens. They're called pens because that's what they look like. This is an insulin pen. They are a convenience item. There is no difference in the insulin that is in the vial and an insulin that's in a cartridge that's in a pen. These are disposable units. In a pen, everything's kind of together. So there's a cartridge that holds the insulin. And it has a window so you can tell if it's clear, if it's cloudy, if something's floating in it. So you can inspect the appearance of the insulin. It has a place where you can attach a needle, so the needles, you have to write separate prescription, they're called pen needles, for the insulin pen. They do not come with it, you have to write separately for them. And these are not replaceable. They used to be replaceable in the old products, but now they're just disposable. So 300 units usually, if it's a U100, it's a 3 mil pen. Okay, so if it's U100, there's 300 units. At the end of that pen is a dial, so the patient can dial up the number of units that they are going to inject. The one thing I like here is that, especially when I'm dealing with patients and I'm worried about how much they pull up or if they have poor eyesight, poor dexterity in trying to use a vial, the pens are great because I feel like I usually get a more accurate amount of insulin injected. So they dial up the amount of insulin, and then after they put the pen needle on, they are going to inject themselves just like they would in all the same places that we've taught them. They'll inject the pen, and then they push down on that button, and it injects it for them. I mean, well, you're injecting it like that. The other thing I find with these is that they're hard to do, especially for older people. Those pens are, the higher the volume, you have to apply a lot of force in order to get the insulin injected. So I find that those are difficult for some populations. Questions about those? Okay, so if people are taking in higher volumes of insulin, I like the vials because I got 1,000. If I've got a pen, I only have 300 units to work with. In some of my patients on Lantus, they may be taking 60, 70, 80, 100 units of Lantus at one time. So how long does a pen last them? 3 days. It's a waste of time. But you just can't fight the drug companies. That's the way they're moving. When patients know a pen exists, that's what they want. So they'll keep pushing you until that's what you give them. So here's what's happened. Because people are larger, they're more insulin resistant. I'm talking more about the type 2s. They've had to start making more concentrated insulin. So now we have U100. If you go back and look at that first page, I've listed for you some of the products. So if you look on page, page 2, under the rapid acting, I've given you some of the different ways that product comes. So they come as U100, U200, U300, and we have a U500. Only regular comes as a U500. Okay. So U100, 100 units per mil. U200, Humalog is the only one that puts out one like that. It's called with their quick pen. So they have 200 units per mil. So in that pen, there's 600 units. In the U300, it only comes in a 1.5. Toujeo is the only one I know that does that. And so there's 450 units. Okay. So now you have to start to know the product to know how many units. So in type 2s, I go a lot to those concentrated units. One is because I can get more doses out of a pen. The others I can inject a smaller volume. So this is Toujeo. It was one of the first ones that came out that was a more concentrated insulin. It's glargine, so it's the same as Lantus, but it's concentrated to 300 units, 1.5 mils, and so it has 450 units of insulin in it. Just approved for adults. So you can see the volume difference in Lantus versus the Toujeo. You can see the difference in the amount injected. I see a big difference when I have to have somebody inject a huge amount of insulin in terms of effects on blood sugar. I've had better results with large volume, with patients on large units with Toujeo versus Lantus. So that's one of the reasons why these have come in, is because people fuss, insurance companies fuss, you could be giving out 10 and 15 pins for a month or two because they're on such large doses. The other thing that happens that I don't like with pins is that when you start using up, when you get down, you may have used all but 20 units. So patients will just toss it. Because if you, let's say your dose is 40 units, you got 20 units left in this pen, you gotta go to a new pen. So instead of giving themselves 2 injections of 20, they may just toss it, okay? It's waste, it's waste. I like the pens, but it irritates me too. On the top of page 7 are the pin needles. Okay? The pin needles, what you have to know about them is you have to order length and you have to order gauge. Okay? One of your prescription practices is doing that. I would advise you do that the next day or two, or else you'll forget in 2 weeks. Is do it after we've talked about it today. So they come in inches, but also millimeters. I just order the millimeters. So it comes in a 4 millimeter, 5 millimeter. There's also there's a 5, there's a 6, there's an 8, and a 12.5, or 12.7. When patients see this one, if they're used to these, they always freak out. Here's how I use these differently. The patients love the micro. It's what they will want. They think it hurts less. It's a smaller needle. They love them. But when I've got really fat, heavy people, there is no way. When they inject a big volume of insulin with a 4 millimeter, it comes right back out. You make a little track, you deposit the insulin, boom, it's just right back out. As you pull the insulin needle out, there it goes. So I really don't like the 4 millimeter unless I'm using a small volume and I've got a fairly thin person. So I will tend to go with the 6 millimeter to start with. 8 if I can get it, but most patients push back because they know. I don't know how they know, but they do. They know that these thinner ones exist. So I usually will start with the 6 in a heavier person. If I'm dealing with a real skinny person or a child, I go with 4 millimeter. Which one do you use,
I
McKenna?
have the micro, the 4.
See, she's normal size. So with her, what volume? What would be the highest volume you would inject?
For just the fast acting?
Any, yeah.
Like 6 units?
Yeah, see, it's nothing, it's nothing. But when you're injecting 60, it's too much. You gotta put it deeper. So that's how I do it. So again, the gauge, the higher the gauge, the thinner the needle. So I always shoot for a 32 or 33 gauge needle. These needles are super thin. They are coated with silicone. They slip in. They are nothing. Well, they're not nothing, but they're close to it. Does your needle, do your injections?
Yeah, it's usually nothing, but sometimes it'll sting or something. But usually it's fine. You don't even feel it.
A lot of the stinging is due to if you drag alcohol. If you clean your area with alcohol and you inject before it dries, it'll sting. Lantus stings because it's a low pH insulin. So some of it's due to that. But these needles are really meant to go in very, very easily and fairly painlessly. Okay, let's take our break and we'll come back at 5 after.